Imagine the sound of a metal saw meeting bone while you feel every single movement of the blade. In 1840, on the American frontier, this was not a nightmare. It was the only path to survival. No ether, no hygiene, and only 60 seconds before traumatic shock would stop your heart. Today we are opening the archives of frontier medicine. I am going to show you the forensic reality of what the human body is capable of enduring when death is the only alternative. I am Vane, and this is the surgery they never taught you in medical school. There was no operating room. There was a kitchen table still sticky with breakfast grease or the back of a covered wagon parked in the dirt under open sky. That was your surgical theater in 1840. No white walls, no sterilized instruments, no trained nurses standing by with gauze and sutures. Just a frontier doctor, often a barber, blacksmith, or anyone willing to pick up a blade, and a patient about to experience agony that would redefine the limits of human endurance. The tools were whatever could be found: a butcher's saw, a hunting knife, a pair of iron shears used for cutting horseshoes. These instruments were not cleaned between uses. They were not even cleaned between patients. The same blade that had just amputated a gangrenous leg was wiped on a dirty apron and used again for the next procedure. Dr. Valentine Mott, one of the most respected surgeons of the era, wrote in his 1841 surgical manual that the condition of the instrument is secondary to the speed of the hand. It did not matter if the saw was rusty or covered in dried blood. What mattered was how fast you could cut through bone before the patient's heart gave out. And that apron. The blood-soaked, crusted, filth-covered leather apron that frontier surgeons wore was not a mark of shame. It was a badge of authority. The more stained it was, the more experienced the surgeon appeared. Medical historian Lindsay Fitzharris documented this phenomenon in her research on pre-antiseptic surgery, noting that surgeons in the mid-19th century actively resisted washing their hands or changing their aprons because they believed the accumulated gore demonstrated their expertise. They had no concept of bacteria. Germ theory would not be widely accepted until the 1860s, 2 full decades after the period we are examining. In 1840, infection was thought to be caused by miasma, bad air, not by the filth embedded under the surgeon's fingernails or the dried intestinal matter on his coat. The patient was held down by whoever was available. Family members, fellow travelers, sometimes just rope tied across the chest and legs. Anesthesia did not exist in any reliable form. Ether would not be demonstrated publicly until 1846. Chloroform came later. In 1840, if you needed your leg removed because a wagon wheel crushed it, you were awake for the entire procedure, fully conscious, fully feeling. The only concession to your suffering was a leather strap placed between your teeth, or if you were unlucky, a lead bullet. Bite down, do not swallow. And for God's sake, do not move, or the saw will slip and take more than just the limb. But even the agony of the procedure itself was only the beginning, because what came next was a race against biology, and the clock was already ticking. Speed was the only anesthetic that worked. A surgeon in 1840 was not judged by precision or skill. He was judged by how fast he could finish. The best operators could amputate a leg in under 60 seconds. The legendary Robert Liston, a Scottish surgeon practicing in London during this exact period, held the record. A complete above-knee amputation in 28 seconds. He was so fast that observers claimed his hands were a blur. But speed was not about showmanship. It was about survival. The human body can only endure so much pain before it shuts down. When tissue is cut without anesthesia, the nervous system floods the brain with pain signals at a rate that overwhelms cognitive function. The heart rate spikes. Blood pressure drops. The body enters a state called neurogenic shock, a catastrophic failure of the autonomic nervous system triggered by unbearable trauma. If the surgery took longer than 2 minutes, the patient's heart often stopped mid-procedure. Not from blood loss, from pain itself. That is why the bite mark on the bullet was considered medical evidence. After the surgery, doctors would examine the lead slug the patient had clenched between their teeth. Deep tooth marks meant the patient had fought through consciousness. Shallow marks, or a bullet that had fallen out of the mouth entirely, indicated the patient had lost consciousness early, either from shock or mercy. Some patients bit so hard they cracked their own molars. The phrase "bite the bullet" was not metaphorical. It was a diagnostic tool. But even a fast surgeon could not prevent what happened the moment the blade touched skin. The body does not wait politely for the procedure to finish. Blood pours, nerves fire. The patient screams until their vocal cords tear, and every second the wound stays open, the risk of death climbs exponentially. Because in 60 seconds you could remove the limb, but you still had to stop the bleeding. And that is where the real horror began. Once the limb was off, the bleeding had to be stopped immediately. There were no clamps, no precise ligatures tied around individual arteries. The solution was brutal and immediate: heat. A flat iron bar was thrust into an open fire until it glowed orange, then pressed directly onto the exposed stump. The sizzle of burning flesh was immediate. The smell, a mix of charred meat and singed hair, filled the room and stuck in the throat of everyone present. This was cauterization, and it was the only method available to seal severed blood vessels before the patient bled out on the table. The theory was sound. Extreme heat coagulates blood and burns tissue shut. But the execution was medieval. The iron was never a controlled temperature. Too cool and it did nothing but add surface burns to an already traumatized body. Too hot, and it destroyed so much tissue that it created a crater of dead meat that would necrotize within days. Frontier doctors had no thermometers, no standards, no margin for error. They heated the iron until it looked right and applied it until the bleeding stopped or the patient passed out. Often both. And then there was the whiskey. Cheap, raw frontier alcohol was poured liberally onto the wound, into the patient's mouth, and sometimes over the instruments in a superstitious attempt at cleanliness. But alcohol, particularly the high-proof rot gut common on the frontier, does not sterilize in the way people believed. It burns, it stings, and critically, it thins the blood. Patients who were given whiskey for the pain often bled more, not less. Dr. Samuel Gross, in his System of Surgery published in 1859, noted that alcohol administered during trauma cases increased hemorrhagic complications and recommended against it. But in 1840, that knowledge had not yet filtered to the frontier. Whiskey was cheap, plentiful, and the only thing resembling medicine that most people had access to. The combination of fire and alcohol created a wound environment that was hostile to healing. The cauterized tissue formed a hard, blackened scab that trapped bacteria beneath it. The alcohol irritated raw nerve endings and damaged surrounding healthy cells. And the entire procedure took place in a room thick with dust, flies, and the same mud that was caked on the wagon wheels outside. Infection was not a risk, it was inevitable. The surgery was over, the limb was gone. The bleeding had stopped. And that is when the real fight for survival began. Because the saw and the fire were not what killed most patients. It was the 48 hours that followed. Within 12 hours, the fever started. The body's core temperature would climb as the immune system recognized the foreign contamination flooding the wound site. Bacteria from the unwashed instruments, the dirt-covered table, the surgeon's filthy hands, all of it had been introduced directly into open tissue. The infection was systemic from the moment the first cut was made. By the second day, the stump would be swollen, hot to the touch, and leaking a foul-smelling discharge that frontier doctors called laudable pus. They believed this pus was a good sign, evidence that the body was expelling bad humors. In reality, it was septicemia. The wound was rotting. Tetanus was common. The bacterium Clostridium tetani lives in soil, and every frontier surgery took place in an environment saturated with it. The first symptom was stiffness in the jaw. Lockjaw, as it was known. Then came full-body muscle spasms so violent they could fracture the patient's own spine. There was no treatment, no antitoxin. Patients died in agony, their bodies rigid and arched backward in a grotesque contortion called opisthotonos. Dr. William Keene, writing decades later in 1905, estimated that tetanus killed nearly 1 in 5 amputation patients during the pre-antiseptic era. Then there was gangrene. If the cauterization had been too aggressive, or if the wound had been closed over dead tissue, the flesh would begin to putrefy. Wet gangrene produced a black, liquefying mass that stank of decay. Gas gangrene, caused by Clostridium perfringens, filled the tissue with bubbles of toxic gas that crackled under the skin when pressed. The only treatment was reamputation, cutting higher up the limb in the hope of staying ahead of the necrosis. Some patients endured 3 or 4 amputations on the same limb, each one removing another few inches, each one resetting the infection clock. Most did not survive the second surgery, but some did. Against all biological odds, a small percentage of frontier patients survived the infection, the fever, and the septic invasion. Why? The answer lies in a grim form of natural selection. People who lived on the frontier had been exposed to pathogens from birth. They drank water contaminated with animal waste. They lived in close quarters with livestock. They handled raw meat, untreated hides, and soil thick with bacteria. Their immune systems were not stronger in the way we think of strength today. They were constantly engaged in low-level warfare. And for a few, that lifetime of exposure created just enough immunological memory to fight off one more infection. They did not survive because of medicine, they survived in spite of it. So what separates 1840 from today? One word: knowledge. The surgery itself has not changed that much. Amputation is still amputation. A saw still cuts through bone. But the difference between screaming agony and waking up pain-free is anesthesia. The difference between dying of infection and walking out of the hospital a week later is antibiotics. A single dose of penicillin, discovered in 1928, would have saved nearly every post-surgical death on the American frontier. The patients who bit through bullets and survived cauterization, only to die 3 days later from septic shock, could have been cured with a pill that costs pennies today. The frontier surgeon was not incompetent. He was fighting a war without weapons. He had no understanding of bacteria, no access to sterile environments, and no time. 60 seconds to cut, 2 minutes before the heart stops, and 48 hours of praying the infection does not win. That was the reality of survival in 1840. The human body proved capable of enduring unimaginable trauma, but it should never have had to. The vault has been opened. The file is closed. I am Vane, and this case is a reminder that modern medicine is not a convenience. It is the only reason most of us are alive. Now, if this investigation gave you a new respect for what your ancestors endured, hit that subscribe button. This channel exists because you refuse to accept sanitized history. Drop a comment and tell me what brutal historical reality we should dissect next. Your input shapes the cases I open. And if you think this story deserves to reach more people, smash that like button. The algorithm only promotes what you tell it matters. The vault stays open as long as you keep it alive. I will see you in the next investigation.